Assalamu alaikum. And I will, Dr. Basir Khazi is here. If you want to unmute Dr. Basir Khazi, you can also chime in few words. We have another 2 minutes before we officially start.
Assalamu alaikum, everyone. Just want to say salam to everyone. And thank you for joining in advance. I'm actually driving, so I'll leave it to Dr. Ismail Shakib to take it away.
So, Jazakallah. I'm going to go ahead and start with أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. Again, thank you all the psychiatry team of CMMA for putting this together in such a short time. I welcome all of you guys on behalf of CMMA, Chicago Muslim Medical Alliance board members, who also behind the scenes has helped with this. Dr. Tajamu Hussain is also part of this, behind all this today. So today, I think the main thing which caused us non-psychiatrists to ask the psychiatry team to help us out is the recent horrific event in Dallas area. We feel sad. We don't know how we can improve ourselves. And usually these kind of events for us is like a tip of the iceberg. And you guys know a lot about this and you are experts in this and you can just guide us through your presentation about different red flags and how we can do it. So I will go ahead and introduce Dr. Ghaus Mohyuddin. He is a doctor of osteopathic medicine. He did child psychiatry and practicing in our Chicagoland area, and he lives in Oak Brook, Illinois. And so, without further delay, Dr. Ghaus Mohyuddin, you can please proceed, and I will keep mute to myself, and all of us will become mute. Give me a second. First, I'll mute everyone, and then I'll unmute you. Now you can unmute yourself.
Assalamu alaikum, everyone. Bismillah ar-Rahman ar-Rahim. And thank you for joining this very urgently done session by CMMA. And I would also like to thank the CMMA team for doing this, especially after the horrific incident that happened in Texas. It really amazes me how less of awareness in general people have about mental illness. And when I talk about that, especially, I refer to basically the communities that we come from back home in India, Pakistan, Bangladesh, and all over the Asian subcontinent, especially, because it has never been mentioned to us, never been stressed to us as to what mental illness is and how important it is. It's really tragic that we had to do this session after such a horrific incident. And I can tell you that after reading that incident, the report and the news of that incident, I personally did not read the manifesto that the kids put on the social media because I kind of sort of knew what there would be. But then when Ismail and Mazhar reached out to me to ask me to do this, I thought it would more be beneficial for me not to read it so that I can answer to the questions of people who already must have read it. So first off, I would like to start off by saying that what we saw there and what we read about in Texas is not a normal thing. It's like the highest level of psychiatric emergency. And thank God that we don't see that quite often. But when we see it, especially happening amongst our community, it hurts really bad and it hits the nerve. And we need to take this as an opportunity to kind of discuss and find out what's going on in our community when it relates to mental illness, depression, especially with the new generation coming up. What we have here in the CMMA, and probably the audience that are joining today, most of them are doctors, most of them are in a phase of their life where they have younger kids or kids having kids. So basically what we are dealing with is our youth that we have to look up to, of our teenagers and adolescent population that we have to look at as the title itself indicates what are the red flags. That's what we are trying to accomplish today in whatever time we have. And I'll try my best to do whatever I can. The reason being, pretty much everyone knows about psychiatry, knows about depression as physicians. But when it comes to our own families, our own communities, we don't tend to focus as much. Because even in my practice, when I see that 80 to 90% of my population that I see is not Indian, Pakistani, Bangladeshi, or from our part of the world. So we cannot tend to ignore it. And we think that we know it. Most of us don't know what's going on in our community. And things have changed a lot, especially after this 1 year of COVID-19, 1 year of isolation. And that has been the biggest challenge. And I deal with the child and adolescent population. 99% of my patients are coming to me because of the isolation, because of the school closures, because of staying home and not able to do anything. I had already done one of such a similar interview in the past on a Canadian TV. That's where I stressed also that biggest challenge that we had at this time is the COVID-19 isolation. But when we see things about the thing that happened in Texas, we talk about depression and anxiety and stuff. So basically, I did not get enough time to prepare a presentation as such, but I did write down lots of notes, and I'll just go through that. What I would say is keep it really simple. This is not going to be like a CME presentation or something that I'm trying to teach someone. What I'm going to do is just let you guys know what the basics are, and then we can have this more like a discussion so that everyone can chime in, and I, to my best of my ability, I can answer the questions. So basically, what is depression? In general terms, depression is a constant feeling of sadness and loss of interest. That's all it is. Sadness and loss of interest, which stops anyone from doing your normal activities. So that's a simple definition of depression. Sadness is a term which is very much different from depression. When you want to differentiate between depression and sadness, in general, we don't do that. Sadness is something that you can overcome, and it's a short term. It could happen by, like, if somebody is ill or somebody loses something, if someone passes away and we feel sad. That's not depression. Depression is something where you have a consistent feeling of sadness, loss of interest in activities that you enjoyed in the past, and so many other things, but it has to last for a very long time. It has to prevent you from doing your daily day-to-day activities. If someone's sad, they can overcome. They still might watch TV or might go and eat when it's time to eat. But when you're depressed, those things go away. You stop doing things that you love to do. You stop eating well. You lose your energy. You fatigue. You slow down. Your activities slow down. And if you're gonna go, it's not like there is scarcity of information about depression. You open up Google, you'll have lots and lots of information. But what my focus today is to put this discussion to a perspective of our community and our feelings and our misconceptions. That's what I want to bring it to. Well, otherwise, I could just sit down here and read up on depression. It's not going to work. So basically, that's depression. That's depression that we need to look at. What do we need for depression? Well, if you want to go for a diagnosis of depression, right, and it has to require specific criteria out there for by the DSM-5 classification, you have to have so many different things, but it has to be present for at least 2 weeks, consistently for 2 weeks, and all these things that I just mentioned, right? So what is depression? What does it do to us in general? I'm going to go that way. And then I'll tell you what to look for in kids, especially, and what to look for in children and adolescents. So in general, if you look at it, major depressive disorder, it accounts for greater mortality and morbidity and financial loss than any other psychiatric illness. Any other psychiatric. And if you read up on this, billions and billions of dollars are being wasted because of major depressive disorder overall in the world. Now, coming back to the United States, it affects 8.3% of adolescent population. 8.3% of adolescent population in the United States suffer from major depressive disorder. Especially in adolescents, it is usually misdiagnosed. The way it's misdiagnosed is called as, oh, it's just a conduct disorder. It's just a behavior, or he will overcome it. Or it might say like, oh, maybe it's an attention deficit. Or somebody might commit like, say, like it's a stage of youth that they're going through. That's like, those are some misconceptions that I wrote down here. It is also associated, the depression, with increased risk of suicide. That is the most important thing. And teen suicide rates have tripled in the past 50 years in the United States. Tripled. So that's why it's more important to differentiate between a depression and just a phase, or just, oh, they're gonna overcome it. Like, and also you need to know that depression in general is in adolescent population is greater in females than males. So that's been studied already. And also it is associated with poor health behaviors and social challenges. Then again, youth who are depressed have trouble relating to their peers. So that becomes a very major issue for peers. If they can, for the children, if they cannot relate to their peers, then they have a tendency to become violent. Because depression leads, first of all, also you guys have to know, this is just like comes from a personal experience, is that kids don't come and tell you I'm depressed. They don't come and tell you I'm sad. One of the biggest things to look for depression in children is irritability. Or are they becoming bullies? That's one of the biggest indicator of depression. If some kids, you notice that they've been fine and suddenly they started bullying others, even bullying their siblings, they need to look at that. So bullying has been recognized as a common behavior among adolescent population. So that's one of the biggest thing they need to know. And also, I wanted to make a statement here that really stood out when I was doing something. This research, I'll read it to you. Give me 1 second. I'm sorry. Yeah, I mean, it says, I was reading a few articles here. It says, teen depression isn't a weakness or something that can be overcome with willpower. I mean, this is, you have to underscore this statement, because this is the most common thing that I come across when I see our community people, right? It can have serious consequences and requires long-term treatment. So the bottom line is, the depression is not something that you can say, okay, it's a phase of life and we can overcome, right? There's so many reasons for that. The biggest reason being that depression leads to kids why do they sometimes get depression? That's another thing. Because the biggest one that I've come across is peer pressure, academic expectations, and changing bodies that bring up a lot of ups and downs. Changing bodies, hormones, and all that, right? So teen depression is not a weakness, as I said before. That is the most important thing that we have to remember. So that was like basic information that I gave you over depression, based on what I feel is there. Now the question is, what do we look for in depression? So I'm not going to go through this as if I'm doing a evaluation of a patient that I would do for, in my practice. But I will just bring out some pointers that you can note down and you can keep looking at. Like why do we, what to look for, right? This is our topic for today. What to look for, right? So number one, I would say go first with emotional changes. What are the emotional changes that you see in kids who can be depressed, are depressed, or becoming depressed, right? So the number one to be alert about these emotional changes are feelings of sadness in a child. If you're seeing that this is something that's not there and you start to see it, right? That's number one. Which could be number one, also could be like crying spells. You've never noticed these crying spells and suddenly the kids start crying for no apparent reason, for nothing. They just start becoming sad, down, and then start crying. Number two thing that you need to look for is frustration and feelings of anger, and as I just said, irritability for very small matters, not major things, right? Suddenly you start to see that kids are becoming irritable, angry. So the way kids normally, or usually, not normal, the way kids usually present to their parents or their teachers or their caretakers when they are depressed is irritability and anger. So always look for that if this is something that you're looking at. Also, they can come and present to you as feeling hopeless. Sometimes they use the words like empty. They say, I'm feeling empty. I mean, they don't know what hopelessness is. If you talk to 11-year-old, 10-year-old, 12-year-old kid, they don't know what hopelessness is. But they'll come and tell you, I'm feeling empty. And they start to show there is no interest in things that they used to do. They are like not doing things that they wanted, right? Usual activities. They're playing, they won't stop playing. Watching TV, stop playing video games, stop doing that. Then what would they do is loss of interest and conflict with family and friends. That's also another thing. So now they start losing friends. They start losing family. So what we call in our psychiatric terminology is isolation. So they start isolating themselves. Parents are calling them for the dinner. They won't come downstairs. They say, I already ate it. I'm not coming in today. So okay, this happened once in a while. Then you start seeing a pattern. So the minute you start seeing a pattern of isolation, irritability, anger, that's when you start to pay attention to it. Then there is something called self-esteem. That's one of the biggest things. Actually, that's one of the major signs of depression, low self-esteem. It starts to show that there is no interest in what they were doing. And I've seen that a lot, especially in our community. When they come in, they show a sudden decline in their grades or their sudden decline in their academic performance. And the parents are really amazed. My child had 4 AP classes. She used to be in like 3 sports. She used to be in tennis, badminton, and now she is in her room, not talking to anyone and not engaging with her. And then parents are like why? They have no answer, no clue why this is happening. So that's one of the red flags. That's what I'm going through here. Feelings of worthlessness and guilt. Guilt is a very, very complicated and a very big topic. It's not easy for us to discuss over here. But if you really, literally just ask a kid, are you feeling guilty? And if they are, they will tell you. They'll tell you yes. And then further you can discuss about that. Next thing is like they blame themselves for things. They blame themselves for every kind of failures, past failures. It's like self-criticism. You've never seen that in your child, and then suddenly they start self-criticizing. I'm not good enough. And then they even go back in their time. Like, remember those times. Even they go back and say, hey, this is what I feel actually happened at the time. Even though they have gone through that, nothing happened, they go back to it. I mean, I've had instances where kids are 16, 17 years of age. They went into therapy just to figure out that sometime in their life, their mom told them that when you were a baby, I was so busy in my life that I was not able to hold you enough. So this child now seeks that statement to analyze it, to figure out, is this why am I really becoming like this now? So even the past thing, they keep going back to it, for no reason. They don't have to go back to it, but they still do it. Same thing with a few more things. Extreme sensitivity to rejection. You've never noticed your child doing this, but then suddenly they start becoming very, what should I say, emotional, or very emotional at little things, tiny little things. They become anxious, and then they have extreme sensitivity. Then the simple things like trouble thinking and concentrating. That's also another simple fact of depression. Like suddenly kids start losing concentration. That's one of the major signs and symptoms of depression. Losing focus and attention. Sleep is a major thing. They start either sleeping too much or they do not sleep enough. Now, when the parent come and tell me, well, my child is up till 3 o'clock in the night, and I went to her room and the lights open. I usually tend to ask them, so did you see in there what were they doing? So here's where the difference comes in. Like if they tell you, well, I saw my child sitting on this computer and playing video games and enjoying it. So that is totally different from a parent telling me, my child is laying in her bed and she's not asleep. The light is on and she's not asleep. So that's different. So you have to differentiate, like, are they really spending their time playing games and having fun, or is it something different? So that's a pretty good, big, what should I say, red flag. And one of the biggest one that everyone should know is frequent thoughts of death, dying, and suicide. Frequent thoughts of death, dying, and suicide. This doesn't mean that they are telling you that they want to die. You talk to them. I tell this to every parent of my patient. Asking your child, are you suicidal, is not going to make them suicidal. It has been studied, it has been proven, and that's how you ask them, are you feeling suicidal? And your child will tell you if they are. Or they will elude the question and go to a different way, trying to make the parents feel not worried. They'll say, well, I had these thoughts. I was thinking about it. Those kind of things. So these are the basic emotional red flags, I would say, that you need to look for when you are discussing this with your child. And remember, I'm talking all of these things relating to adolescent child population, anywhere between 6, 7, 8, 9, all the way up to 18 plus years of age, 18, 19, 20. So that was the emotional part of it. Then I'll tell you something about what kind of changes you should look in their behaviors in child population. What would be that? Number one is loss of energy and tiredness. That would be their major complaint. I'm feeling tired all the time. I'm feeling tired all the time. I already mentioned about sleep and insomnia. Lack of appetite, that's the big one. Or sometimes they eat too much. Lack of appetite and eating too much, both of them are part of the depressive syndrome. Same thing, we talked about. One thing that I think this could stand up as a red flag, but then again, I guess this could really relate to our communities and population is frequent complaints of unexplained body aches, which we generally tend to call in our thing as a somatization or hypochondriasis. Not that thing. Like frequent aches, like headaches, body aches. If they're in school, they're always complaining of sometimes nausea, sometimes going to the school nurse more often. So that's another behavior change that you see. I already spoke to you about social isolation. There are some issues that you need to know in behavioral changes. As biggest one is, which I bet people will talk to me about after reading that posting on the social media, is self-harm. Self-harm is the biggest red flag for depression and anxiety. More for anxiety than depression, I would say. because this has somehow become a cultural thing in this country that kids learn from their peers is self-harming helps you with your anxiety. And I always tell them this is like a very, very poor coping skill for you. So they have basically minimized it or basically made it into more of a social thing to self-harm. Somebody might come to and tell me, oh, I'm just self-harming, I'm not suicidal. I'm just self-harming, I'm not. So when I ask them why do you do that, they say, well, that's how sometimes my coping skill is. That's how I get rid of my anxiety. I would like to feel pain. So if a child, 12-year-old, 13-year-old, 14-year-old child is telling you that I need to resort to self-harm to get rid of my anxiety, that is a very big red flag, very dangerous red flag. We do not and should not expect our children to use this kind of a coping skill to get rid of their anxiety. So I would really stress on that. Now, what you have to do is in these situations, you have to figure out, right? What is normal and what is not. Like kids are coming and telling you, I'm feeling tired, I'm feeling anxious. So where do we draw the line? Like what do we tell them, and how do we look for to figure out, like, is this more of a just of something that's passing by? Is my child sad, or is it something more than that? So what you look for is the pattern, the consistency. If you're seeing that there is a consistent pattern of anything of these things that I just told you, a few of those red flags, then you look for it. That's a red flag. Then you seek help. I mean, we have amazing doctors on this panel, pediatricians, family practitioners, general practitioners. I think 30 to 40% of their practice is basically psychiatry, because it's not possible for everyone to get to psychiatrists all the time. So they also can use these red flags as an opportunity to kind of educate their patients, their patient population, pediatricians especially, and they have a lot of resources online that they can go and use it to help their own patients, right? So the biggest thing is you have to talk to your child, talk to your teen, talk to your adolescent, and figure out what's going on. If you wanna go into a little bit of a more of a detail, like why do these things happen? I can say that one of the biggest predictor of depression is family history of depression. Family history of depression is the biggest predictor of depression. If nothing's going on, go into family history. There does not have to be a trigger all the time, right? It does not have to be an event happen to have for someone to have depression or anxiety for that matter. So it's neurotransmitters and neurochemistry and the developing brain. As you know, that human brain develops till 24 years of age. And basically the frontal lobe of the brain is the executive function. And that's what is not fully developed in teenagers. And so it's really hard for them to, at some times, to figure out as to what is going on with me. When I ask them, hey, is something going on? Is something happening? They say, no, there is no trigger, there is no event that I can find sometimes from the patients to predict that why is this child having depression. So some of them could be hormones, because the body is changing, hormones are changing. That's one thing that you need to look into. And trauma is also a big concern. Childhood trauma. And childhood trauma could be of any kind. It could be physical, emotional, or sexual. And it's really hard in our population to get to that. It's very critical, but it is very tricky, and it's very challenging for the psychiatrists to get there. We have like, so many things happen in our families, in our communities, that we cannot and we do not want to talk about. Biggest thing is physical, emotional trauma, which we do not think about. I had a child who tells me the other day, when I was growing up, my dad would discipline me. And at that point, this is like a 20-year-old patient basically. And she's telling me that this I thought usually was a normal thing. But now, when I went to college and started talking to people about this, I realized that actually it was not. So now she's going through what should I say, a flashback kind of thing about her trauma. So we usually don't look at physical abuse or even emotional abuse as trauma. It doesn't have to be, physical in the sense like doesn't have to be like if you look into the criteria for trauma, sometimes when DCFS talks about, was there a physical mark on your body? It doesn't have to be a physical mark or a physical thing. It could be emotional. It could be the way we talk to our kids, the way we expect things from them. Those also can fall into the category of trauma. Biggest one would be, as a child, loss of a parent. Loss of a parent is a major thing for a child. And that can be a big predictor of depression as the child grows. So those are the things. And then it comes to what our children are going through. Like I wanted to kind of touch base on this before we go more into discussion part. The reason I want to do that is this, that what we are seeing now is a population of our kids who most of them grew over here and are going to American schools and American colleges. We, and I include myself in that, I mean, we bring our culture from our countries, and then we expect that we instill that in our kids, which is good. But we don't know and we don't realize that these kids are spending more time of their life in American schools, American colleges, American kids, American peers, who are a different culture than what we are. So basically, sometimes I realize that kids are living two lives. You know, they live a life in the house and they live a life in their peers. So I used to tell this, I really saw this. I'm going to give you a really simple example. I used to go to pick up my daughter from Islamic Foundation School. And I'm sitting there in the car and I'm seeing all the kids come out, very happy, enjoying, laughing and stuff. And this is not just with my kid. Every person in the line I'm standing, I was noticing that. Kids come out of the doorway really happy, laughing nicely. The minute they see their parents, their entire demeanor changes. So I actually told this to my daughter, like, you're happy when you are with your friends and your party the minute you saw me. So that needs to be really discussed and addressed. Like, why did that happen? So why are we making this a challenge for the kid, basically, to go through this kind of behavior? And this is just a simple example I gave you that I just observed. And this, I'm talking about, like, at least, this is like 6, 7, 8 years ago, what I'm talking about. What we are now compared to that time is entirely different. With the COVID, everything has changed. And with COVID, not even before COVID until now, I'm seeing an amazing change in the culture of this country, in the kid population, adolescents and teens, and what they have been exposed to and what they have access to. Like, I'll give you a really good example, and we really are hesitant to talk about this with our kids. And I would like you to take it hear it out and tell me what you think about it, and I would learn from you too. Like, we have always and never, as a family, as a parent and children, discuss this thing. And we expect the kids to know about it, and we cannot assume that they know about it and they'll be okay with that. For instance, I'll give you an example. We know that we have, as a child psychiatrist, I'm going through this, and it amazes me how this has evolved. We know what homosexuality, lesbian and gays, right? So what we know of as doctors is LGBT and Q. That's all I knew till like a few years ago. Then after that, I actually counted it down and wrote down here right before this started to just bring it up to you. So now I counted 11, but there's more of those things. So if I want to go through that, I'll read through it. Somebody is unmuted. Can we kind of? Okay, that's fine. So what I was going to say is this. So if you're going to take a note of this, count on your fingers. Now we have lesbian, gay, bisexual, trisexual, queer, pansexual, non-binary, gender neutral, asexual, closeted, fluid, heterosexual, and intersex. This is all I could come up with. And this is based on my interaction with my patients. And trust me, our population is not immune from this. I have seen Muslim children who come to me and they are struggling with this thing that they are really worried to talk to their parents. I give you a really good clinical example. 14-year-old girl came to me, this is like a year ago, and she was hospitalized, inpatient, because she was trying to kill herself. And she mentioned it to her school social worker, she's planning to kill herself. So obviously, the minute you mention it, it's brought up to the notice of the school and they send her to the hospital. So she was hospitalized and I'm talking to her. The biggest thing that she was worried about is having her hijab on when she was in the hospital. So we gave the accommodation that yes, you can have your hijab on when you're in the population. When you go to bed, you give the hijab to the nurse, and she agreed to that. Now I'm talking to her and I'm saying, so what is it that is making you so depressed and so upset that you want to kill yourself? And she has cut marks on her arms, on her wrists. She cut herself actually. So we are discussing that. So she said, here's the thing. I feel that I am pansexual. And I don't know how to discuss this with my parents. So I realized that because of this, there's not going to be a time where I will be able to address this with my mom or dad. So I thought I might as well die. So now when I speak to mom and dad, they had no clue about what their daughter was saying. And then I said, what do you think about her cutting herself on her wrist? Mom says, well, she said to me that she fell in her gym class. And that's how she injured herself. So this is how it starts. This is where we are. And this is our kids, our young generation going into this community where we have chosen to come to. But we are not educated enough. And I can tell you, I can confess you that I, at that point, didn't know what pansexual was. And I had to read up on it. And that's why I started to pay more interest and more attention towards this, like what is going on and what are these things and how we address. It is becoming hard for psychiatrists to document their notes, because the minute you walk in, you are told to address this child as they, them, not he and she. And this is not just happening to American population, African American population, Hispanic population. Our kids are with them. So we need to know them. So I would like to stop here discussing this because this is such a big topic that we could go on. But I would like to hear from our esteemed population that we have here in this Zoom conference. And I would like to learn from you, and I would like to address anything that I can to my ability. Thank you.
All right. Thank you so much, Dr. Mohiuddin. That was a lot of information and a lot of things to think about for the parents, going home. If there are questions, we would be willing to take some questions. I think we have perhaps 15 minutes or more. So we'll try to answer some questions. So the audience can type their questions, or Ismail, is there possibility of just asking? Can they ask the question directly, or they have to type it?
No, I think they can type in, ask, I can unmute them, but I have some questions here. Uh, One is for anyone in the psych team here. What's the age to talk about Islamic standing on suicide with our own kids? Like, what age is appropriate? Because I'm a little bit surprised when Dr. Mohiuddin mentioned that he's for kids, for adolescents or stuff. He's saying from 8 years onwards is because for me, for normal people, kids, teens means 13, 14, but nowadays kids have more
Yeah.
information that we know. So based on that, when is the appropriate time for me to bring about Islamic standing on suicide? Because that is one of my tools which I can use to strengthen them. So that would be one of the questions.
Well, I can tell you that. Number one, I'm not educated enough to comment on a Islamic perspective of anything. I'm just here to learn from you too. But what I can tell you is this: human mind is able to remember things from 4 years or 5 years about, right? And the suicide, you can pivot this question a little bit as to what is the age when a child can understand death. The child can understand death at 6 years of age. So if they know what death is, they can also understand what suicide is. But I'm not going to tell you what is the Islamic thing to do with it, because I'm not educated enough to tell you that. I can tell you. Plus, I think suicide has nothing to do. If you want to discuss suicide, it has nothing to do with Islam. What I believe is, if you could teach children what death is, what life is, and separately teach what Islam is, they will understand it.
But my question was more that was part, but it was not about Islam itself. But we all, as we were growing older, we were told in some way or shape in the masjids or anywhere a passing comment that Islam prohibits suicide.
Prohibits suicide.
Right.
Yeah,
So
that's
my
all I
question,
know.
that was
Yeah,
my main question. When do I talk to my kid? Just saying a simple statement,
right.
Islam prohibits suicide. So that age. So you are saying that age would be 6 years.
Anywhere from 6 years
Yeah,
and older.
that was my
Yeah,
question. Like,
yeah, yeah.
that's okay. I think some questions came. I think Dr. Mazhar.
Just looking up here.
I don't know, Ismail, if can people could unmute themselves, can they?
Yeah, I think they could. Let me see.
Because
Yes, we could. Everybody can do it.
Yeah, they
okay.
can do it. Yeah, they
Okay.
can do it
So
actually.
if
There
you
is,
want to unmute and ask a question,
There is
that's
one
fine,
more
or you can type.
question. There is one more question. What is the difference, or how do we, as primary care physicians slash parents, differentiate between teen tantrums versus anxiety versus depression?
Yeah, that's a good question. As I said, I mean, anytime you see a pattern in it, see, anxiety is basically, I mean, you could read up on anxiety what it is. It's like anything that you feel is making a kid worry or become anxious, basically. And there are signs of it, like they're fidgeting, or they're biting their nails, pulling their hair. So again, if that's the thing, and you see that happening over and over again, if it's a pattern of it, like yeah, once in a while there's a temper tantrum, somebody didn't get their toy that they want, but which is usually normal. But then if you see it happening over and over and over again, then probably that's when you should look at it in a different way.
Okay. Any other question?
The second question there is, how can we help someone who had thought of suicide but doesn't follow through because it's against Islam? This is coming from someone who said her mother verbally or emotionally abuses her. So I think basically the question is this person who thought of it, but is well connected to Islam, that they took Islam as a good means and did not do it.
Right.
So
So the basic thing is, when somebody comes and tells you that I have been having suicidal ideations. That should basically tell you that this is something that is not happening overnight. This did not happen yesterday. For someone to get to a point where they are talking about suicide is a major red flag. Of course, they can tell you, yeah, I didn't follow through on it, but I did have this thought. So having a suicidal thought is telling you what? Like this person has gone through enough time in their life that they become so depressed and they are at a point where they are thinking about suicide. Yeah, they used Islamic teaching as not to follow through on that. But sometimes, and it has been studied, we in psychiatric population, psychiatric field know that how much do you think the time is between someone having a suicidal ideation and actually following through on it? If anyone can just chime in.
Are you saying how much time is?
Yeah, how much of the time does it need for someone to have a suicidal thought and actually go through it, an intense suicidal thought, and go through it if it's not interrupted?
3 to 6 months.
5 minutes.
Oh,
5 minutes. If someone has an intense suicidal thought, and then that's why we have these suicide hotlines. And that's why we do safety planning when a patient is discharged. Like, who are you going to reach out to the minute you have a suicidal thought? And that's why I asked you guys that asking someone, are you suicidal, is not going to make them suicidal. So bottom line is this: if someone's talking about suicide, that means it is something that you should immediately take into consideration. Reach out, go to a therapist, go to a doctor, go to a psychiatrist. Start off with your pediatrician. I would always do that if it's a period that age, because it's not easy for our population to accept the fact that, oh, I have to go to a psychiatrist. For that matter, any population. So start off with your pediatrician. Go from there, seek the help of a therapist. Then seek the help of a psychiatrist if you can. That's what I would say.
I want to add a little bit. In fact, in every patient we see as a psychiatrist, when they come, in each visit we ask them about suicidality and document it in our note. That is, mandatory for us to do that, because we have to ask them and document and take appropriate steps when they said that they are feeling sad or suicidal or those kind of things, and we have to send them to therapy sessions or whatever we can do as soon as possible, and safety plan, as you said.
That's true. Thank you.
This is Dr. Here. I would like to add a few points here from psychosocial aspect. I see one of the questions like what kind of coping mechanisms or parental kind of things they can do to help the kids. Basically in our community, the important part is to know that it's definitely a cultural barrier. It's considered like a stigma for dealing with mental disorders. And then also there's a lack of adequate insurance coverage, or sometimes not able to see the physicians, as one of the doctors just posted, the pediatrician. So indeed, it's a big issue with that. And apparently it leads to a lot of other things also, like what Dr. Mo has mentioned about all the symptoms. One of the things that he mentioned about the negative self-statement about themselves, that is the key factor also to be taken, because that's like almost like a tip of the iceberg. You start seeing them talking more negative about themselves, then it's time to have an open dialogue. The problem is sometimes the well-meaning family members can do more harm by showing resistance to talk about these issues, which based on their conservative outlook or whatever might be the reason, but that puts the kids to shut down. So I've had a lot of patients in my office where the parents are sitting outside and this kid is in 30 to 40 minutes speaking their heart out. Parents have no clue about what's going on in their life. So it's unfortunate to see that they're able to talk to a stranger, but not to their own parents. So it's always important for the parents to start a dialogue. Sometimes these are difficult talks, but obviously it's like, at the end result is much better. The other thing I would like to mention about is like, definitely in our community, the way it goes, there's a lot of bullying actually it's going on, as Dr. Mo has mentioned. So it's not only the person who goes through depression involves in bullying, but it also impacts the kids who goes through the bullying also. because somebody was asking me recently, how does the bullying cause depression? I mean, the whole hypothesis is like kids who get bullied, they tend to spend a lot of time ruminating on the experience they go over. And they run these all scenarios in their head, thinking about what they could have said back or what they could have reacted differently. So it does impact a lot in terms of how, especially if their temperament is like more towards prone for anxiety or depression, they are hugely impacted with that. So the take home points are for some of the parents as well as like the primary care doctors are, if you see a persistent mild to moderate like depressive symptoms, and especially with impairments in the academics, and if there's a past history of depressive episodes, definitely it requires a non-emergency referral. And as Dr. Mo said, if you hear them making any suicidal statements or threats or involved in any self-injurious behaviors, and even to some point exhibiting mild paranoia, that's an emergency referral, no questions about that, because the best outcomes can be only achieved if you address it faster. I've had a lot of patients coming to our office saying like, we have tried this herbal medicine, this medicine from India, Pakistan, or whatever the country may be. And then they also tells me, oh, we're trying the religious leader kind of, which is fine, you know, nothing against that. But please do not delay in the treatment from getting into more serious problems. And that's where it happens. A lot of times in our community, what I see is most of the kids who are brought to us are in severe state of depression or anxiety. So it's very important if you can be dealt with when in mild, moderate stage, the outcome is much better and shorter and easy on the family.
I'm actually going to allude to what Dr. Waliuddin just said. Like, and also there is a question here. I didn't know that there was a chat going on. It says, if depression can be hereditary from any of the parent, and what are the role of parent to prevent such situation? Also, is there any alternative methodology of therapy without medications or for anxiety, depression, and suicidal ideations among children? Like, as Dr. Waliuddin just said, I mean, these are the kind of questions that we deal with every day in and out, because somehow the first thing that comes to mind is alternative medication when it comes to psychiatry, because there's so much stigma about it, and so much stigma about the medications. People feel that they have to be in medication for their entire life, which is not the real scenario, which is not the real situation if you really look at it. And again, also Dr. Waliuddin mentioned about people going to your clergy, going to your alim or mufti. I can tell you, the kids in this when it comes to religious learning, this is my observation. I mean, no way or in any sense I'm telling that this is right or wrong. What I've seen is kids, when it comes to religious talk or hearing about it, are very concrete. I'll give you a really good example. Recently, 20-year-old girl, she came to a hospital. She was hospitalized, inpatient, Muslim girl, because she would not come inside her house, and she would stand outside of the house for 8 hours straight. And eventually mom had to call 911. The reason for that, I'll tell you what. This, after I discussed with this and I spoke to the parents, I realized mom's telling me that she has been doing this kind of behavior for 1 year. For 1 year, and she has been doing it, and they never, ever focused on it. You know what she did? And this, as I said, no way in shape or form I'm saying this name to bring something distinct. She was watching videos online, right? Videos of Islamic scholars. So when I asked her, she's the one who told me that. Well, I watch and I follow Mufti Menek. Okay, I said, okay, that's good. What did Mufti Menek said that you had to do things like this? So he said that alcohol is an intoxicant. I said, okay, fine, that's right. That's what he said, that's good. So what did you do? So she said that she threw away the entire shampoos that she had in her house, all the detergents that she had in her house, all the perfumes that she had in her house, all the medications that she had in her house. And she's been not taking a shower with a soap or a shampoo, washing her clothes only with baking soda, and she's not allowing her parents to take their medications. And on top of it, she shaved her head twice.
Okay.
I said, why did you shave your head? She said, well, I took a shower with a shampoo, which I think has alcohol in it. So sometimes kids become this concrete.
Just in the interest of time, I think we got just 2 minutes left. There is a question here I would like to read, and then maybe Waluddin or Dr. Mo can answer this. So this question is from a pediatrician, and he or she is saying that you know this pediatrician sees kids with depression or anxiety, and since it is not possible to get a psychiatry appointment, so this doctor is asking, can he or she, I don't know who this is, I think Dr. Zakia Zaman, okay. Dr. Zaman is asking this question, can she put the adolescents on antidepressant, and can she monitor them? So,
Yes, I can answer that. So no, absolutely, yes. The reason is, as Dr. Mo said, like almost 30 to 40% of the patients are seen in the primary care practice. However, I know with the recent news in the media about the suicide and all that, I don't think that should deter you away, because you'll be doing more service than not. So what I would recommend for the primary care doctors or pediatricians is use the PHQ-9, which is a depression module. It has been validated for use in the primary care. And definitely it's not a screening tool for depression, but once you start the treatment, it can be used to monitor the severity of the depression and response to treatment. So that is definitely a very good tool at your hand. You can monitor it on every, and the good part about that is children and adolescents tend to provide more reliable information about their emotional state than about their behaviors. Usually the parents tends to know more about the behaviors, but if you have to get the right information, always directly ask about their emotional state and they will tell you the right information. So yes, definitely to answer your questions, definitely you should start, even if it's a low dosage. There's no point in waiting for weeks or months. Another important point I would like to mention is when we started the practice several years ago, they were like 86% of the psychologists or the therapists were like Caucasians or whites. But what happened is in the last 5 or 6 years, I have seen, alhamdulillah, there's amazing, like a new, excellent group of therapists that has emerged, which is helping the community in great deal. Because the problem is I used to refer people to the American psychologists or therapists, and they have no clue about the cultural sensitivities. So there were several cases they were told, oh, you don't have to be religious and things like that, because they didn't know about the cultural sensitivities, which is helping a great deal now with this new group of therapists that has emerged, especially I know about the Chicago area now.
okay, there is another question, and the speakers try to keep your answers short so that we can cover as much as possible. It's already 9 o'clock, so I can probably take a liberty of another 2 or 3 minutes. So keep your answers really short. So there's another question, which says, are these antidepressants lifelong?
It depends on.
Go ahead.
May I answer? So it depends. We have to start the antidepressant and monitor them and see how they are responding. It's if it's first episode of major depressive disorder, it is recommended that we have to at least keep them on antidepressant for 6 to 8 months, sometime a year, 1 year at least, and then see how they are responding,
Okay.
And sometimes they need to be all lifelong, but it depends on case to case. It's not one size fits all.
Okay. The other question, I think it's rather a comment from one of the doctors who is saying that kids watch all these different kinds of cartoons, and some of them have violent themes in them. So he's just expressing a concern and making a point that maybe parents should be involved into knowing what kids are watching. Many of these cartoons are inappropriate for a variety of different reasons. So it is no longer PG-13 or 17 or whatever it is. Everything is beyond mature audience. So that just doesn't make any sense. If it says PG-13, it's not PG-13 anymore. It's not even appropriate for adult audience to live about 13 years of age. Then there is another question here. I think maybe this is the last question, and then I think
Uh,
we'll wrap it up.
Dr. Mazhar will let the team go continue. I think Dr. Amir Mohyuddin is from Dallas Muslim Medical Alliance.
Mhm.
He wants to give a minute on because he lives right there where this namaz janazas are going on for last 2 days. So, Dr. Amir, do you want to give a minute? He's a family physician too.
Absolutely. Okay.
Uh, Dr. Amir,
Yes.
if you can unmute.
So, Assalamu alaikum, everyone.
Walaikum
I
salam.
hope, Jazakallah, mashallah, you all have great talent in Chicago, subhanAllah. I've been hearing for the past 1 hour, mashallah. Great points have been discussed. I just wanted to add a very important component of what's going on in the community. And or you might not be aware. And mashallah, since this is an audience of all physicians from Chicago, I just wanted to end and add one note. Be on a lookout for something called contagion effect, and I'm sure the psychiatrist would confirm this. That there's something called contagion effect or copycat effect. So actually, my own patient, I was his PCP, a kid. Again, even after this incident in Allen that all of you are aware about, there's one more incident that happened, and my patient's janaza was today. Actually, unfortunately, one more youth took his life, and there were 7 more suicides last evening here in the Dallas area, but they were all failed suicides. And there was one more suicide in New Jersey, and he was copying exactly what the kid did in Allen. So I just wanted to make sure, as physicians, when this happens, be on a lookout in your private practices, and even pediatricians and family medicine physicians, be on a lookout for this thing that will happen is parents might bring their patients, kids to your offices. So that's one thing, I highly recommend all of you to keep an eye on in the next 2 weeks. And we had today Dr. Rania from Stanford University, who specializes in youth suicide prevention. And inshallah, she's a key speaker tomorrow. Tomorrow we have Sheikh Yasser Khadi and our Texas Medical Board president, and her speaking on youth suicide prevention. So all of you are welcome to join, inshallah. It's part of our Muslim Medical Alliance effort altogether, inshallah. So I just wanted to make sure I just want all of you also to leave with this tonight, that in your own practices, keep an eye on this effect, because it's not just Dallas. This thing happened in New Jersey because the kids read the full pact of this kids here in Dallas online. So, mashallah, Chicago is a big town. So please be on a lookout. Jazakallah.
Okay. I have a question for the experts. And I think the audience will also get something out of this. I think there are some non-medical audience also in this. I realize it now. So depression, usually depressed patients do not kill other people. Depressed patients usually kill themselves. Now, this particular the horrific incidents that happened in Texas raises a lot of different questions, and one of the question is, did these kids, did they really have just their depression? Because we psychiatrists understand depression is not just one entity. There are varieties of depression, and one of them is bipolar disorder. So the question is, what do you think might have happened with these kids that they decided to not only kill themselves, but kill their parents, their grandmother? I mean, that was just shocking. This lady was 71 years of age, and their younger sister, who was actually a twin, but one of the suicide victim. So, what do you guys think? Like, what was that? Was there something beyond depression that might have happened that led them to take such a horrific step?
Actually, one of the counselors who's working with this family was in a meeting today. She did not disclose a lot of things, of course, because of patient privacy, but there was a lot of comorbid diseases this kids had, of course, bipolar disorder being one of them. And they've been struggling for the past 6 years almost. And the family, alhamdulillah, no blame. The father, the parents were very diligent. They were taking them to offices, and they were, getting them the right treatment, but looks like they were a little bit beyond, like as you had initially said it, this case was an extreme case, even unheard of in a lot of psychiatry practices. One biggest problem also that I'm sure a lot of you psychiatrists also face is whenever you have Muslim parents bring you kids, they would not accept the treatment. As you said, your last question was, how long do they need to take this treatment for life or temporary? That's one thing. They're hesitant to bring their kids to, like they would bring the kids to psychiatrist offices, but they would not agree to put them on medication. So, using our community resources, community show to talk about this problem in the community is one way we thought would mitigate this problem.
What I would say is to to Mazhar's question is this, what my take on it is, because when I initially started to read about the snippets of this thing, not the entire manifesto, what they were talking about, and even the news articles were saying that these kids were very smart kids. And they were in, high achievers and stuff. But then they also mentioned in their note, I guess, which I read, is that they do not want their parents and their family to suffer after they kill themselves. So their thought process, if you really look at it, there's a really fine line between having extreme intelligence and tipping towards the mental illness. So if you look at it, what they were saying that, hey, we are going to kill ourselves, that's true, but let's not make our parents and our families suffer.
Yeah.
So that also is one of what you just said. And plus there could be more than depression, what you're talking about. Yes.
Yeah.
There has been several cases like that in the past, like murder-suicides. And most of the time, that was the inference from that, is like people didn't want the other people to suffer after they've gone, so that they have killed the whole families in that. But yes, there has been several cases, different countries.
One of the things that that has come in my studies, which I think would help the non-psychiatry medical specialist in this, is for a child, early childhood adversaries.
Right.
You can go and Google this, non-psychiatrist clinicians. You will read tons and tons of material. Early childhood adversaries is number one risk factor for all mental illnesses, medical illnesses. Now you'll be surprised, like, what are you talking about? Medical illnesses? Absolutely. Early childhood adversaries puts you at risk for diabetes, heart disease, stroke, you name it. Every general medical condition that you can think of, you are at higher risk if your childhood was messed up.
Correct.
Now, we as a parents, we don't take this seriously. You know what? I mean, we are so busy. Most of the parents are working, both husband and wife are working. We have, so much work outside. We don't have time for our kid. So the child is deprived of emotional support, our physical presence, you know, just a hug, saying your child, I love you, asking the child like how his day was. So we spend 12 hours outside in our offices. We come home, we still bring the work home, and we are always doing something for everybody else. But what are we doing for our child? How much time we have? So when we think about this as a depression, we are always talking about the secondary approach. Why are we not talking about the primary approach? Why are we not talking about preventing it from happening?
If you have time, I'll give you a really quick thing that everyone can do. And actually, this was told to me by a family of a kid, not our community, but an American guy. He said what they do every night is this. First of all, everyone knows that we like to do the dinner together as a family, right? That we try to practice. But this guy told me a step ahead of beyond that. He said we have dinner every night together, and when we sit down on the dining table, that is everybody's safe zone. So every kid, parent can talk anything they want openly on that dining table, and they will discuss it, and they will not talk about it after that. If they need help, they'll get them help. If not, they can talk about anything. You have any question about anyone without any hesitation, We talk it on the dining table, we discuss it, and we are not judgmental about it. And we don't talk about it after we leave the dining table. So that's a very good way of having our kids open up. And also, someone asked here, is there a hotline for Muslim teens to discuss their issues anonymously with professional psychologists, psychiatrists, or ulema? If anyone knows it, please go ahead and let the audience know. I don't know.
Khalil Center, I believe, has a hotline. I could be wrong. I don't know if it's 24 hours or not, but they do have services that extend out.
There's one
Okay,
called
Dr. Haja, I think, has a
Nasiha.org from
Yes.
Ontario, Canada.
I have
Dr. Haja, please go ahead.
Yes, I have a question for the panelists. You know, depression and other psych issues, there is still a big taboo in our society. How could we improve that? How could we, you know, this is a wonderful information that it's for me too. I'm a physician. So how could we bring this to our community?
Oh, I mean, Dr. Khaja, this is kind of very important. But one thing you start at home, there are some things that has been mentioned. It's intergenerational trauma. Basically what happens here is, like, you know, a lot of parents have a tendency to talk about their depressive and oppressive stories, which it is unintentional, but that get passed on to the next generation. Their intention is to encourage the children to do well in life, or they could be venting themselves. But what happens is that has a huge impact on the child's development, because they keep growing with that kind of stories. So obviously this kid is kind of, his horizons are like limited in terms of how they much process. And then of course, like any emotion, like how you present in terms of like children, they tend to replicate in terms of like how the modeling going on there. As you know, I have a lot of kids tell me that the parents come home and just talk about the political events and disappointments. And the kids don't have those tools to process. I mean, we adults, we can process it on our own way and get away with it. But you leave them with that doubt, and then they feel more insecure inside themselves. The other most important thing a lot of kids have told me about is that some of the parents have told them that they represent their family, they have to represent their family well in the community. And that makes it more difficult. And they have to be kind of, you know, reflective upon the family's success. It's a lot of burden. I have a friend, physician, both husband and wife, only daughter. She's under so much tremendous pressure because consciously or subconsciously, they're pushing her that she has to become a doctor, and she doesn't want to. So it's like a big like resentment going on in the family there. So
Okay.
there are certain things that we have to incorporate in the house.
There was a question from Nadia. I can't see her name now. She was trying to ask a question. Nadia Mohyuddin, I think. If
Oh,
you're
I'm sorry. No, I wasn't trying to ask a question. I was just answering from the chat. There is a Muslim hotline known as Nasiha from Ontario, Canada. So I was just providing that resource in the chat. Sorry to interrupt the previous conversation.
Okay, so it's a nasiha.org for Muslim hotline. Okay, thank you so much. All right, I think there are.
My comment and question to the panel is, mashallah, we are from Asian countries, and even here, every kid in the house is different, right? Every kid, the approach you take with each kid is different. So this is away from the Dallas incident. So how much time is enough? How much is not enough? Because it's common tendency, if anything goes wrong, we blame the parents first, because obviously they're, but how much is the parent to be blamed? And is there a real disease there? Because if there is serious illness there, the blame game can continue, but if you don't go to a psychiatrist or proper treatment, that's going to have a long-term impact, as you guys are saying. And with this taboo in our society, if somebody walks out of your office, that itself is a taboo if somebody sees you going in and coming out. So it is a lot of pressure. So I think you guys have done a great job, and some of the comments here were, how do we get this, what you have in your mind, to general community? So it takes years probably to get the taboo out, because as they mentioned, one medication can be lifelong or not. And you know, these kids are going to get married and people will say, oh, this so and so probably is on depression medications, be careful. So
No, I mean, medication and all those things comes later. But see, if there's something that parents have noticed, like not away from normal behavior, I would definitely start with a therapist and a counselor. That should be non-biased. That should not have any taboo because we have to move forward with that. Otherwise, what's going to happen is, with the time they will kind of, do okay, but it's going to reflect more as they grow older. It could be more marital issues. It could be more other issues that persist. It will not go away because we have seen that happening. I have seen like a whole one generation so far. And I do see that the people who I used to see as teenagers, they are young mothers now. And they are having a hard time handling their 3 or 5 year old. They just bring those 5 years old to the office and ask us to fix them. But in fact, the problem is not the child. The problem is them. So that's why I say start with the therapist. And if the things kind of resolve mild to moderate, that's perfect. If not, they will definitely refer them to the psychiatrist or whatever the higher step may be. But I
I
would,
think it's about time that we get over this taboo factor. I mean, we have a new generation that's coming in, and they cannot handle this world if we are still stuck in that taboo. We need to go beyond it. And I guess, as Ismail said, we need to educate our community. That's the only way we will be able to get rid of their doubts. And as Dr. Waliuddin said, we are not even talking about medication now. Let's start basic. Let's start get rid of taboo. To talk more about it. Where are the kids going to go if they have doubts? They'll go to their peers, and the peers have no answers.
I have
That's what
one
this is happening.
one comment about. So there are two reasons, right, for not accepting mental illness as a real or genuine illness. If it is from faith point of view, if they think that, you know what, we are Muslims and we shouldn't be depressed, there is a saying in Urdu that naumidi di kufr hai. So being hopeless is takes you to kufr. Islam is the first religion which recognized mental illness.
Right.
Recognized mental illness. I was taking a CME course through a practice here, and he actually mentioned in his writing that, and he didn't say the best, Prophet Muhammad, peace be upon him, he just said Muhammad was the first man who said there is treatment for every illness. I was shocked when I read that. I'm taking a psychiatry CME course, and this guy says Muhammad was the first man who said every single disease has a treatment. The person should go and get help. And Quran says that. There is an ayah in Quran which says, if you are in doubt, go and ask the person who is expert. Fas'alu ahl zikr in kuntum la ta'lamun. There is ayah in Quran, and there are hufaz here. I think one of the doctors are hufaz. They can correct me if I'm wrong. So which says that if you are in doubt, go and ask the experts. So go and ask the experts. Why are you becoming experts if you're not expert in that field?
Right.
Number two, let me give an example to the parents. If your car shows a sign, check engine light, lights up, you can get away with it for a day or 2 days, 3 days, right? What's going to happen one day? Your car is going to stop on the highway and you'll be stranded there in the middle of the night. What will be your condition? Think about your child. And the problem with mental illness is, since you cannot draw the blood or take a CT scan of the head and say this child has depression or anxiety or bipolar disorder, something that we cannot see with our eyes, we don't believe in it. And that's the reason why a lot of people, I see patients from Muslim patients and even patients of other faith, and many of them have this kind of feeling like, what, I feel like I'm weak, I shouldn't have this. And this person is taking medication for diabetes, cholesterol, blood pressure. I'm asking him, why are you taking all these different medication? Well, he says, because I have diabetes, I have high cholesterol. I'm like, well, then why are you so different about mental illness? Well, he says, Well, then he thought for a second, then, for a minute, and then he goes, well, because my brain is the most important part of my body, so that's why I don't want any medication to influence it and the way I think. I said, well, actually, it is helping you to think better, improving your distorted thinking that is taking you towards, feeling hopeless and not have any, enthusiasm about your life. So actually, it is taking you towards the positivity from your negativity. So you should actually be, grateful that you have a treatment option available to help you think positively. Um, so that's I wanted to just add that for some of the parents who are still not really on board with getting help for their children and loved ones. So,
I give only like 3 points, like take home message for the parents. Like definitely there has to be an increased awareness of risk of depression and its symptoms before it gets worse. And God forbid it should not happen to anybody, but if it is, then there's treatment. The second thing is ensure the availability of a culturally sensitive clinician. Just don't take them to anybody, because a lot of times it so happens the kids have rebelled against the parents. So culturally sensitive clinician is very important. So there are a lot of new, young, dynamic therapists. Please contact them and kind of do that. The last thing is focus on helping family members to find culturally acceptable ways of talking like you're uncomfortable and thoughts and feelings, because that's where the thin line is. What happens is they never ask, you never tell, and that gap remains until they get married or whatever might be the case. It has impacted so many lives in terms of their education, their social norms, their relationships, and all of that.
Yeah, I think we are to an end now. I would like Dr. Basir Khazi to give a vote of thanks to all the participants and conclude with the dua. I've introduced Dr. Basir Khazi is a gastroenterologist and a mashallah hafiz and born and raised in Chicago area. So he connects well with mashallah all the born and raised people here. And before he starts, I'm going to just tell you one thing. As mental illness is important, at the same time physical fitness at any age. So mashallah, a group of Muslim physicians have started Gains Fitness, and it's in Oakbrook Terrace. Majority of us can make use of it. There are a lot of programs, and I strongly believe physical and mental health is important even for us at our age. Without any further delay, Dr. Basir Khazi will give a word of thanks and then dua, and we can conclude it.
Jazakallah khair, Dr. Shakib. This talk was so much I learned myself as an individual. So Jazakallah khair to our presenter and our panelists, Dr. Wass Mohyuddin, amazing job. Dr. Mazhar Goliwale, excellent taking the conversation into various direction. Dr. Wali, your points, Dr. Khatija Vaid, and all others that have contributed. We really thank you on behalf of Dr. Jamal Hussain, Dr. Usman Shakib, and the rest of the board. We really are very appreciative. This is a very important topic, and I think this opens the door for many of us that have already started doing this, but talking about mental illness in our own households, in our family. And as we approach Ramadan, this is such an important month that we all, inshallah ta'ala, will conclude here. And Dr. Mohyuddin as well from Dallas joining in. But I think this is a great time. We need dawa and dua. That's what my grandmother used to say, right? Dawa ke saath dua. So this is our holy time that's starting. So inshallah ta'ala, Allahumma salli ala Sayyidina Muhammad وعلى آل محمد وبارك وسلم. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار وقنا عذاب القبر وقنا عذاب الحشر وقنا عذاب السكرات. Oh Allah, please bless our panelists that have educated all of us today. Allow us to take the knowledge we have, the knowledge we learn, and to implement this and improve the physical, the mental health within our own households, within our own families, within our own friend circle, within our own community. Allow us to improve the mental health of the community in these trying times of COVID-19. Oh Allah subhanahu wa ta'ala, allow us to see the month of Ramadan. Oh Allah subhanahu wa ta'ala, give us the barakah of the month of Ramadan to improve our spirituality, to improve our physical well-being, to to improve our mental illness, Ya Allah. Oh Allah, keep us together. We are bound together in this group as healthcare professionals and by our deen, Ya Allah. Allah give khair and barakah in the homes of everyone who have attended today, our friends and our family, inshallah. Ameen bi rahmatika ya arhamar rahimin. Walhamdulillahi rabbil alameen.
Jazakallah khair, Dr. Kazim. MashaAllah.
Assalamu alaikum, everyone.
Alaikum salam wa rahmatullahi wa barakatuh.
Wa alaikum assalam.